Hi, my name is Dr. Ramachandran. I am from India. Herewith, I'm just presenting the poster called the Unmet Medical Needs in People with Type 2 Diabetes Treated by Insulin. In fact, I represent a group called the International Diabetes Management Practice Study Group called the IDMPS. To introduce the IDMPS is the largest ongoing global cross-sectional observational study recording the real-world data on patients' profiles, management, and patterns of care in people with diabetes across the developing countries. We have data collected from different waves from 2005 to 2017. In this particular presentation, I'll give you the data from a subpopulation collected from two waves, 2005 and 2017. So the data is from 27 countries across Africa, Eurasia, the Middle East, and Southeast Asia. We have taken a subpopulation from the total two waves, and the two waves had 15,000 patients. And the selection criteria from that 15,000 patients was type 2 diabetes, availability of HbA1c value, and the patient should be on premixed or basal insulin. With this criteria, out of the 15,000, we had approximately 3,000 patients, half on premixed insulin, the other half treated with basal insulin. So basically, we are now trying to compare the characteristics of the patients who are treated either with premixed insulin or basal insulin in this particular cohort. As you can see, the results showed that from the table 1, as you can see here, there's a modest statistically significant differences were observed between the patients on premixed insulin versus basal insulin for age, sex, and type 2 diabetes duration. Patients on premixed insulin had a longer disease duration but received fewer oral hypoglycemic lowering agents. Total insulin dose was higher in patients on premixed insulin versus basal insulin. Frequency of micro and macrovascular complications rates were similar in both the groups, as you can see in the figure 1. Moreover, most importantly, the patterns on premixed insulin had higher fasting plasma glucose compared to and postprandial plasma glucose compared to those on basal insulin. Therefore, the control of glycemia based on fasting and postprandial plasma glucose was better in those patients treated with basal insulin. Adjusted comparisons indicated that the mean HbA1c was statistically significantly lower with basal insulin compared to premixed insulin, 8.4% versus 8.8%. And the number of factors which were actually adjusted for included treatment group, age, sex, and duration of type 2 diabetes. HbA1c control was observed in approximately 1 of 5 patients in treatment group. Significantly more patients achieved HbA1c less than 7% in the basal insulin group compared to the premixed insulin, this was actually adjusted with the variables that I just now talked about. So the proportion of patients who had HbA1c below 7% was significantly higher in patients who were treated with basal insulin. More patients on premixed insulin compared to basal insulin experienced hypoglycemia in the preceding 3 months, 32.5 versus almost 20%. However, the statistical significance for between treatment differences in the hypoglycemia was not maintained when adjusted for age, gender, and type 2 duration of diabetes. So, in the real-world practice, approximately 1 in 5 patients on either premixed insulin or basal insulin achieved glycemic targets for HbA1c, and high rates of hypoglycemia were noted. So you can say that approximately 80% of patients in type 2 diabetes in the IDMPS database treated with premixed or basal insulin did not achieve adequate glycemic control. But however, we should stress the fact those patients who were treated with basal insulin had significantly better HbA1c compared to those patients who were treated with premixed insulin. However, I think there is a lot of scope for improvement. So to conclude, newer therapeutic strategies with improved benefit risk profiles for glycemic control and less hypoglycemia may be clinically relevant for such patients and should be considered in future. Thank you.